Welcome everybody back, and thank you for being part of this. We're thrilled, Ricki, to have you here. Beyond thrilled. It's just been such an educational experience, and I don't know if any of you guys have had a chance to speak with any clients about it. Some of those questions, actually, I wrote in relationship to clients asking questions. So great, really excited to hear Ricki, your take on some of these things. I'm hoping that you guys are getting information out there, and hopefully that this is a discussion that you can carry on. And you can always point people back to the recordings that we've done and posted. The recording's free. We're not making any money off of it or anything. It's just so that we can help get this information out there, which is actually what Ricki and I first talked about when we spoke, is that her mission is just to get the information out there. So our goal is to help that happen. I'll let you take it from there.
I made a new slide set and I retitled it. I said, we can prepare for menopause and know what to do. So in honor of all of you, just to say, all right, we talked about the history of humans, the history of hormones, women compared to men. We talked about some of the early warning signs and the various life stages and some of the science behind these important details, and then hopefully how to navigate with your clinician. And I touched a little bit upon insurance issues. That's all about coding. And then also that it really takes time and we have to make time for that. And so it really hit me early on in my educational adventures is that most of us really never think about the origin of menopause. Certainly doctors don't think about it, and it's a big part of the problem of why medicine in general, but in particular women's medicine, has not addressed the shift in the demographics. So when you have this evolutionary biologic framework, the sort of fingernail sketches that you and I as women are basically inheriting the physical changes and hormonal events that were selected for evolutionarily to nurse mammals. So if you look at other mammals, like the non-human primates and horses and cows and dogs and cats, well, dogs and cats are a little bit different because they're protected species. But when you look at animals in the wild, they do not have a natural menopause and live very long. Some of the great apes do live about 6 months to a year, but they don't live for 30 years after cessation of fertile capacity. So cessation of fertile capacity is a long way to say menopause. And so what we inherit is a biology that was selected for in earlier stages of human mammalian evolution when estrogen levels were low. Well, when is that? It's really isolated to either when you were an infant and the other hormones are developing and helping us finally mature and adolesce, but mostly it's only when we are breastfeeding. And so in 2022, I will go on record as saying the reason that menopause is treated very differently from thyroid deficiency is because men do not have menopause. So this is a patriarchal constraint, socially, medically. Medicare, all of this reflects the attitude of men. And women my age were educated by male paradigm medicine. So even though we have lots and lots of data, and we'll touch upon that again today to answer a lot of your musculoskeletal questions about tendon tears and all these injuries that seem to come a dime a dozen for older women. Like one of the questions, doing the same thing, now I have an injury. Why is that? So this is all basically related to the fundamental persistent deficiency of estrogen, estradiol, our most powerful estrogen. So we know from breastfeeding, this is brilliant. It happens when the prolactin rises and that shuts off the ovaries. They basically go to sleep. Now you mobilize calcium from bones. It's great for the milk. you mobilize, you make more fat, you put that into the serum, it's decanted in the milk. That, again, great for the newborn. Some of these warming, hot flashes, poor sleep, it probably helps us warm the infant, be alert in the, cave or the hut to predators. So all these things that do not make for a healthy, really older human female, they're great in the short period of time after a baby is born and we are nursing. And that phrase there, complex HPA, that's hypothalamic, pituitary, adrenal, on top of your kidney axis. So we have all these adaptive mechanisms that kick in when we're nursing, decrease maternal agitation and help us put up with a lot of the sleeplessness. But unfortunately, they don't kick in when you're menopausal, which is a big part of mood disorders in menopause. So this other aspect is to look at the lifespan. So that's really the most important takeaway for all of us. If we died even at age 49, as we did in 1900, no problem, okay? That's not the case. So if you're going to live another 30 or 40 years without estrogen, without any adaptive evolutionary occurrence to support it, that is why the answer to the musculoskeletal injury questions is yes, it is directly related and attributable to all the cascade of effects of tissue changes, which are measurable, but no one reads this literature. So we know about the bones. I'll show you some pictures I didn't show you before, but this is the population of women by the millions, decades of age. And you can just see, and I was talking with a patient earlier this morning. She was born in 1960. And I said, yeah, look at 1960. That is the dawning of women over 75. And, I look back at 1951 when I was born, you didn't see a lot of old ladies. My grandma, who was about 65 then, she was really old looking. So these are the things that, why wouldn't doctors think about this? We didn't get that in medical school, and we certainly didn't get it later. So this disease burden data that Dr. Barzilai published in the Journal of American Medical Association, again, most gynecologists would never read that journal anyway, but he is an internist and he's very concerned about the mounting number of health issues that are burdens for women. Just to remind everybody, what do we mostly die of? We die of heart disease. That's a lot, directly attributable to heart disease. Other includes diabetes, other aspects of cardiovascular disease. You can see pneumonia is actually a pretty small part, but when you already have heart disease and you get a touch of pneumonia and you die, your diagnosis is still heart disease, like an older person. But you can see here the things that women freak out about. In fact, the breast cancer deaths account in recent, this slide is about 10 years old, it's down to about 2.4% of deaths are from breast cancer. And lung cancer, it actually exceeds that. Now it's almost 6%. And then other cancers. So I just like us to pay attention. The big gorillas are metabolism, that, diabetes, heart disease, and that's really what we're dying from. So here's a picture I didn't show you last time. I just think this is a very helpful thing. And, if you want to upload the slide set and have it in your, office or treatment center, when you see patients, this is what osteoporosis looks like when you take a microscopic image of bone, and you can see how easy it would be to break your hip if your hip is made up with that kind of bone versus a hip made up with this kind of bone. So these are inevitabilities if you live long enough with estrogen deficiency. Again, as I said, you're mobilizing calcium and protein from bone stores to feed that baby when you're lactating, but you compensate once you start to menstruate and ovulate again. This is also something I didn't dare to really show you before because it's a little complicated, but I think that really helps it stick. So this is a cross section of a normal artery. If you look down at the bottom of that picture, you'll see age 35 to 45. These are average American women. Now, I'm guessing that your Pilates clients are not average. I'll bet you don't have a lot of morbidly obese women in your classes, but you have plenty of overweight women. These are average overweight, mildly obese women. That's who we study because that's who makes up the majority of women in these age groups today. So what you can see here is with time going from 35 to 45, now going from 45 to 55, you can see how the artery is now this red lumen through which blood is going to flow. It's getting a little smaller because the inflammatory depositions of plaque and the fibrous cap are growing because of what? Because of bad lifestyle, bad diet with too much saturated fat. Average 55 to 65-year-old, these are just observational data sets doing ultrasound imaging of the carotid artery right here. These are women just being normal, chubby American ladies. And this is what their arteries then look like. So you can see this lumen is reduced at least 50% by age 55, 65. So that study that was done, the Women's Health Initiative, the average age of entry of women was 63 and a half. So this was the artery type of those ladies. And they were given oral estrogen, which we've talked about, increases clotting. So then this is what happened. So that whole study and today's talk is 1 month away from the 20th anniversary of that devastating and error-ridden release of that report that it caused heart attack, strokes, or breast cancer. So just very quickly to finish it up, if you start hormone therapy early, that whole middle row, you can tell, doesn't advance much. Advances a teeny bit, but not much. And then if you go the distance and give hormone therapy late, you are going to precipitate events. So that, in a nutshell, is why you ideally want to start early. And one of the questions asked today was a woman, is an excellent question, 58 years old, had menopause 4 years ago, pretty miserable, has the usual miseries with the hot flashes, poor sleep. Now, the last couple of years, painful sex. All right. This woman is still considered early hormone therapy because she has not been menopausal for 10 years. So the data set from the United States supports, without batting an eye or asking any more questions, it would be the standard care say, well, you're actually still in the early menopausal group. Yes, we should give you estrogen. I would add to that, if there's a family history of high cholesterol, if there's a family history of heart attacks and strokes, for sure that woman should start transdermal estrogen. So just to answer a super great question, which is about hormone therapy starting within the first 10 years of menopause, that's considered timely and not considered late in the American data set. So we know all about these symptoms. You've all talked about it. You know, the Pilates teacher, probably not too much with the brain fog discussion, but maybe lousy sleep because they're tired and they want to work as hard. But the stiff joints, the arthritis, and the just sense of not being very energetic, this is clearly what exercise physiologists are faced with. Huge data has come out since we've had our first talk in April, more data about Alzheimer's and the lifetime risk really being acquired in these early years of estrogen deficiency. So I'm bold about this now. I was a little more delicate in my speech before, but I think it's super important for those of us who, you know, really would like a good brain forever. It's absolutely imperative. Optimal cognition is having estrogen present in the brain. I included this slide, which I think I did show you briefly before, but just to remind you, the fallout after the study in 2002 was fear of breast cancer. And that's what you hear your hairdresser says it, your girlfriend says it. oh my God, you're going to get breast cancer if you take estrogen. So this is, again, I'm a weirdo. I read the medical literature. What a novel way to spend your free time. Here's 22 years in that Women's Health Initiative. This is in women who started estrogen between age 50 and 60, which is kind of, that's our age group. The top curve is Premarin plus medroxyprogesterone acetate, and this is invasive breast cancer. You don't have to be a rocket scientist to see that that is more than the women 0 on nothing. This is women on nothing. These are death rates from breast cancer and death rates from other cancers. They were also slightly increased. The absolute risk of this, in fact, was about 6 additional breast cancers in 10,000 women years of use. That is such a minor number. It really is not clinically significant. And in fact, when they reanalyzed the data, they realized, in fact, if you really controlled for breast cancer risk in this clinical trial, all of these numbers, the bad stuff, in fact, goes away, because it turns out the randomization wasn't perfect. But I'm not going to even go there, because what I want you to see, medroxyprogesterone acetate, this MPA thing, which virtually no one uses anymore. When you don't include that with your estrogen, you see at the same period of time that Women's Health Initiative came out, you see already the estrogen only group that had a hysterectomy, they have less breast cancer. And again, you don't have to be a super scientist to see this line goes down. So the incidence of invasive breast cancer, in fact, was lower, and it stayed lower for 22 years. So I just want to bring to everyone's awareness that the oft repeated phrase that estrogen causes breast cancer is not supported by actual science. So, but because it was that fear that has made the environment in which all of you are living very anti-estrogen, that American study sort of poisoned the well. Just to balance, and again, because Zena is in the EU, although Denmark's not in the EU, the Scandinavian countries have similar data sets because they have national health insurance, which hopefully one day we will too. But meaning, I want to show you the Danish osteoporosis study, which was a similar double-blinded randomized trial. And interestingly, this trial, they had women within 9 months of their final menstrual period enter this study. I just want you to see hazard risk. If it's less than 1, it means when you were on treatment, you had fewer bad things. This happens to be breast cancer. And again, that's what women terrorize each other, saying, oh no, you're going to get breast cancer if you're on estrogen. Have you ever heard that? Yes, we've all heard that. Your hairdresser will tell you for sure. So anyway, I just want you to see that even their combined treatment was norethindrone, not medroxyprogesterone acetate, a different progestin. By the way, that's the most common old progestin that's in birth control pills. So they actually saw less breast cancer. When they did constant, when they did sequential norethindrone acetate, that's what NITA is. They gave it cyclically. It looks about the same, 0.58, it's pretty close to 0.6. Then when they gave estradiol alone, it's 0.55. Okay, that's even a little bit less. The point is, it's not more breast cancer. So then they unblinded it and just continued to follow these women, and they still had less breast cancer, especially, once again, just like our WHI, estrogen alone, significantly less breast cancer. So I just want you to see, this is validated not just in our quirky American data set. And then back to the boys club. Remember, look at men there at the tippy top here. Their testosterone goes the distance. And very importantly, their estradiol goes the distance. So I'm going to move our little, there we go. So I just want you to see, remember, this is age 83. So men have ample testosterone. They have about a 15% decline in testosterone overall by 83. but they have no decline in their estradiol. This estrogen level, if you draw the blood and actually put a number on it, is about where women would be in full menopause wearing a 0.05 patch. You and I, we know what happens to us around the 40s, our estradiol declines and it forever goes to zip. The absolute number here would be about 5 if our assay went down that low. Remember, our average estradiol number when we're young and menstruating, normal cycles, is 100 to 125. So these are severe deficiency states compared to normal reproductive age groups. And I don't want to say we should be at the same level as when we were younger, but I want to suggest that there are reasons sometimes to seek a higher level. And here's one of them, because you've had so many great questions about bones and tendons and ligaments. These are different doses of estrogen, and it's wonderful to see the comparison of spine, which is on your left, and femoral neck, which is hip on the right. And so you can see the 7.9, that's the highest dose, 0.1 of the transdermal. And then the 6.4, this is percentage of accumulation in bone density over 2 years. So you can see it's quite a dose response relationship, kind of cool to see. And you can also see that the hip is a lot more stingy. The hip mineralizes more slowly than does the spine. That's in every study, different kind of bone in the hip and the spine, which you probably know. But in any event, my point is that any dose of estrogen prevents bone loss and actually increases the amount of bone you will build or your client will build over 2 years. So it is a dose response. So we know gender medicine matters. Female bodies are unique. We're wired differently. We have to have a different lifestyle to stay healthy. We generally have more hip, knee, ankle, and foot problems because we have a wider hip from our stance. If you look at most men, their pelvis, their knees, their feet are in a line. There's not a lateralizing or a medial displacement effect. So, you know, when you just look at your client standing and you say stand about a hip width apart, that's not the way they normally stand. So these are just subtle things, but we do it a million times in our lifetime. So we emphasize these displacements, and therefore, you know, the knees tell the tale and give us hell. We have those inherited factors. That was the last slide. I find this very memorable. When you think that genetics kind of load the gun of risk, and epigenetics pulls the trigger. What's epigenetics? It's everything listed. It's your nutrition, hydration, you know, toxin exposure. It's your exercise, good or bad. You know, these are all the things that are within our grasp. So as much as I preach about the importance of hormones, the factors that are all under our individual control. And I just think, especially because you're all teachers, the more you can model attention to these difficult to master skills of upping my happiness, especially in the face of horrible, wow, since we were last together, I mean, have we had bad news, dump on our doorstep from the Supreme Court to these poor people in Uvalde, and then more mass shootings. And this Senate that's absolutely dysfunctional. Yeah, we have stress, but think of the sisterhood. Think of how much we need to step up and kick the patriarchy to the curb. So see how I've radicalized just since April. So this is where I really feel strongly that paying attention to mood is huge, because if we're becoming less involved socially because we're actually a little bit depressed, anxious, or, you know, more self-conscious than ever, we need to take care of that. We need to, you know, reach out. If a friend has a therapist they really like, well, try that therapist. But especially if we have family history, personal history, mood is tremendously important. And I mean, I feel so blessed because I'm connected to the best job in the world, which is taking care of women. So that was just our quick review so that we can, get into questions again. There's a beautiful question about DHEA here. And I may have told you this anecdote before, but I'll repeat myself. So I was at a medical meeting, it's probably about 10, 12 years ago. And I was chatting with this man, Fernand Labrie, who's a French Canadian, and he's spent his whole career, he's a little older than I am. So he's been a total weirdo in that space. DHEA is his molecule. He probably knows more than any person on the planet about DHEA and women's health. The reason DHEA is not available in Europe is because it is converted to testosterone. So it is an anabolic steroid. And so guess what? Athletes, gym rats abuse it. And so in Europe, you cannot just go to Pharmaca or the vitamin shoppy and get DHEA, or Whole Foods sells it too. Whereas in the United States, we can. Honestly, it's kind of an anachronism that it's still available. However, since it is, it's kept it cheap. But the problem is that who knows what's in it unless something is really FDA level of scrutiny and purity and ascertainment that there's no false ingredient and that the amount on the label is in fact what's in the capsule. So there are a couple companies, Pure Encapsulation I've mentioned before. You can buy it online or at Pharmaca. I think Whole Foods sells it too. And the other in the United States that's easy, I think they deliver to Britain, maybe the EU, is Thorne, Thorne. These two nutritional houses were founded by people who actually believe in independent laboratory certification of their product, and they're proud of it. So they pay extra to belong to this. And so they have independent testing, random lots. And my experience clinically using those brands, and it's not keto DHEA, it's regular DHEA. When they add the keto steroid molecule, it actually prevents it from being converted to testosterone. So details matter. Just plain old DHEA, 25 milligrams is a good dose range to start for women. And the reason I want to go into detail with this answer is I stood up at the menopause meeting about 10 years ago. And, I'd written the book on bioidentical hormones, and I mentioned DHEA in the book because I read the 750-page monograph that Fernand Labrie gave me. And why he gave it to me is I went up to him after one of his talks and I said, oh my God, I was giving a lecture. And this doc was just grilling me all over the place, telling me there's no data about that. And I said, well, sir, there is data. Like you can go to PubMed and read a lot. I think about 26,000 articles come out if you just put in DHEA human, whatever, as your search engine. Anyway, so Fernand Labrie said, well, you can have my monograph. So he produces this book that's it's all these abstracts about DHEA, and he put them all in a book. Anyway, so I know I'm an outlier. However, if you read the endocrinology of the brain in detail, and I think Lisa Mosconi touches upon this in her XX brain book, there's actually conversion of DHEA inside neurons and glial cells in the brain itself, and particularly in gray matter. So that's interesting to me. Why is that interesting? Because the body is pretty conservative in terms of just toting around hormone enzyme capabilities. You don't do everything in every tissue. Like you make the thyroid precursors in your thyroid, but then interestingly, you activate it in your kidney and your liver. So the body does some really interesting things. So we synthesize all of our sex steroid hormones from cholesterol. And if you look at the pathway, and you could just go to Wikipedia or Google and just ask for the steroid synthesis pathway in human females. And you look at it, you'll see all the chicken wire diagrams, which I showed you some of them before, but it's fascinating. And so I don't take that as proof that if the brain has that enzyme, it must be important there. But I kind of trust nature more than I trust somebody else's opinion, because nature happened. And so I really feel, looking at evolutionary medicine, which you could Google, and you'll probably get a whole lot of articles out of the departments in Harvard, and I think University of Michigan, University of Wisconsin, I think in Madison, has another department of evolutionary medicine. These departments get underfunded at medical schools, and so they come and go. But that is wisdom. Those people are doing the diligence to try and figure out, why do we have so much diabetes? Well, if you look at the metabolism evolutionarily that we were gifted with, that was selected for very slowly over eons of time, it wasn't made to handle so much of a carbohydrate load. And that's where, you know, when you're working with elite athletes and you look at some of these high power, you know, glucose, I look at Sports Basement in their nutritional stuff. I mean, I never buy it, but I just look to see what they're selling to these, you know, long distance bikers and the triathlon people. Anyway, those are rare uses of massive doses of sugar. For normal people, that's not okay. We're not going to burn it up. It just creates a huge load and demand on the system. So back to evolutionary biology of food and nutrients, if we only had the kind of wisdom to see women are very different from men, and part of our biologic selective hormonal adaptations to lactation in a food scarcity evolutionary eons of time. In fact, guess what? They've discovered in the last few years, all these subtle things, ghrelin, leptins, they do make it easier to gain weight, because in fact, you do become a more efficient machine, tragically enough, at needing fewer calories to maintain your weight. And so all these complaints, all these years, women say, I gained that, 5 pounds every year. It's mostly around the middle. It's so discouraging. I haven't really changed my lifestyle. I'm not drinking more wine. And doctors pretty much patronize and say, yeah, that's what happens. I think it's important for you to know, yes, unfortunately, that is what happens. So what change do I have to make? I can't change that yet. We don't have a good drug to change it. I have to exercise more and eat a little bit less. And I think I've said it to you in every session together. I love to eat more than I need to eat. So I had to change. I'm only barely 5'2", So anyway, in our culture, that's not an easy thing. It requires mindfulness at meals and in between. So anyway, but I'm worth it. I'm worth the effort. So are you. So are all your clients. And, these are the things. Hypermobility. If that's your curse, by the way, I'm also hypermobile, which we didn't even have that word. I was good at ballet, great at yoga, oh, great, until you get to be 60. And then, all those joints are not quite in perfect alignment. Hypermobility, much worse if your collagen loss is greater, if it's more difficult to build and maintain muscle mass, and if you lose the resilient elasticity and durability of tendons and ligaments. So hypermobile women suffer even more than, quote, regular non-Ehlers-Danlos women. So everything, they have more hernias. They have more second repairs of the hernia requiring a mesh. They have a lot more pelvic floor surgery, the little sling for the bladder, but all of these things. So I really feel for all the women, certainly in my age group, women 10 years younger, but women right now in their 50s, Now that generation is the first generation, maybe if we can turn around this fear of estrogen support, to have good prevention. And the musculoskeletal aspects of the subtle anatomic oddities, where, you know, the shoulder anatomy, the way the head of the humerus goes in, not quite right. Okay, until 50, you can usually get away with it unless you had some bad ski accidents or, you know, tennis crashes or something. After that, when most women, again, 89% are severely estrogen deficient. I mean, I'd be curious, maybe if all of you after today's talk would just email Zaina and let her know approximately how many or how few, what percentage of your clients are on estrogen. That would be very helpful. And again, I can't be everybody's doctor, unfortunately. And it's why in the second and the first slide set, I really gave you kind of the crib sheet of how to approach your own care providers. Notice I don't say doctors, because a lot of women, they see excellent nurse practitioners or PAs, and I'm all in favor of that, because generally they're going to listen better and take a little longer in your care. But I think tendon ruptures, tendon tears, clearly there. In fact, I just pulled it up because my neighbor a couple doors down, the husband actually tore his Achilles playing pickleball, of all things. That gives me pause. But I thought that was a pretty innocuous pseudo tennis kind of thing. But anyway, but it was a man, so, you know, he wasn't estrogen deficient. But those tendon ruptures and patellar tendon difficulties, all of that, you know, ACL tears, medial lateral collateral ligament tears, you know, rotator cuff tears. I mean, it just stacks up, and anything and nothing can cause a tear, because gradually, just like we see with the bones, if you do serial analyses of the actual thickness of a tendon and especially, you know, ligaments, they also wither without estrogen. So and injuries heal much more slowly. By the way, blood flow is a big part of that too. And again, I showed you the picture of the diameter of the artery. Estrogen actually causes mild dilation of arteries from the heart to the aorta to the femoral arteries. So the other thing that causes arteries to dilate is demand. So when you ride a stationary bike, or do an elliptical trainer, or you're hiking up a hill, you know, when you first start going, you get to that point in about 3 or 4 minutes and you just feel like, oh my God, I'm so out of shape today. And then boom, you're better, because your lactic acid buildup peripherally, you vasodilated your peripheral circulation, and now you're much more energetic. So we always have to remember that hump. But for women not on estrogen, they don't have that reactive, elastic vasodilation to the degree that estrogenized women do. So there are many subtle things. So they get more discouraged with exercise because, quote, it's just not happening for them. To say nothing of low mood and poor sleep that probably make you not feel like pushing through. So the other specific question, this wonderful question a woman asked, was about dose. Getting the right dose is important. Being on anything 025, 0375, which are in the vast majority of women not going to be enough, but it's better than nothing. I just saw a patient. She's kind of been off her wagon. She's gained 10 pounds. She's on 0375 dot patch, which is particular questioner. That's what her doctor, she begged and begged because she still was having hot flash and insomnia. So she got up to a whopping 0375. This chubby, darling, retired woman, her estradiol blew me away. It was 57. That's very uncharacteristically high. My estradiol is about 57 on a 0.1 patch, almost 3 times her dose. Well, there's a big difference between my metabolic rate. I'm much more like, the hamster on the hamster wheel compared to her. So even though I'm little, I burn through my hormones at a faster rate, which is typical of people who actually do exercise. So if you can get a blood test with, and I would ask for the ultra sensitive, because if you're at Kaiser or a lot of the, Palo Alto Medical Foundation, they give these assays that say less than 50. Well, 47 is less than 50, and so is 17. And 47 is probably good enough. 17 is not good enough. So that's the other thing I would say. On the other hand, if you are still symptomatic, your brain is not happy. Your brain is not happy because, in fact, it does not have enough estrogen. And that, if you read Lisa Mosconi's XX brain, results in metabolism inside neurons. It's not good for your head and not good for your, being smart and intelligent your whole life. And I think all of us feel very much aligned that please goddess, not dementia. Breast cancer, we sort of touched upon it. Oh, I want to mention one other thing. Interestingly enough, 100 milligrams of progesterone, especially FDA, not fly by night, some Texas or Women's International Pharmacy, I do not trust their products. From Walgreens, CVS, Rite Aid, whatever, pharmacy, FDA approved, 100 milligrams of progesterone pretty much keeps everybody's uterine lining, whether you're at the low dose 0.25 or at the 0.1, keeps it thin for the vast majority of women. It's almost like that dose kind of shuts down the growth patterns of the uterine lining. And so for the vast majority of us, it's going to be the same 100 milligrams, even though we increase estrogen. That was a great question someone asked. But from an osteoporosis perspective, higher dose, at least until bones are better, even if hot flashes are gone. But for the woman who is still symptomatic, has insomnia, wakes up 2:30, 3:30, can't get back to sleep, super alert, that woman, you don't need a blood test. She is still symptomatically low. And so I want to be really clear, because sometimes doctors they're dinged, by the way. If you're in a managed care captive group, if you order more lab work than your colleagues, they don't say, oh, that's so nice, you're being sensitive and meeting your patient's needs. No, they say, you're an outlier, you're costing us money. And they actually get dinged, and they get paid less per visit, and they get paid a smaller piece of the pie at the end of the year if there was profit in their health plan. So there's a lot going on to discourage clinicians from saying yes to every test you might ask for. So if you're symptomatic and those are your symptoms, or still joint stiffness, dry eye, you don't need a blood test. You need a little higher dose. And that's the other thing. Try the higher dose for 3 months. See if it helps. No clinician is going to argue with that. Okay, all right, I don't believe in it, but you can tell. So, but you have to be kind of a pushy advocate. And I don't think in my lifetime I'm going to see a culture shift in medicine about our attitude meaning healthcare system writ large towards aging women. Remember, most women in my age group, they have not worked for a living. They haven't contributed to the Social Security fund. They haven't paid income taxes. They've been a drain on the system. And so now when they're older women, they're just a cost, a center of cost. And that's the attitude. And I swear, I've been to plenty of meetings to say, I'm not making this up. So I just saw a patient today. She lives in North Carolina. Her 32-year-old new primary care doctor told her that she can have a mammogram every 3 years. Well, if you look at the data, that's not good. She's 65. In fact, your risk goes up for breast cancer per annum. The single greatest risk increase is age. So these are all things, if I'm going to be an advocate for women, I'll tell you the truth. The guidelines from the expert associations, which are really the breast cancer surgeons and the radiologists who image and do the biopsies, when they see something suspicious. And clearly annual mammography reduces the need for a mastectomy, and it reduces the death rate from breast cancer. The calculation is that we have to spend about 220,000 extra screening dollars to find that one woman that we're actually going to make a big difference in her quality of life and her years of life. So I guess we're not worth it. $250,000, not worth it. So these are the calculations that go into the hopper of the U.S. Preventive Services Task Force. What they're really preventing is cost of screening. They're not really preventing more breast cancers, finding them early and resulting in good care. So I'm a real advocate for annual screening. No one loves it. I mean, it's not the most pleasant thing, but it sure beats finding a palpable lump. If you look at the difference in the data between a palpable lump and the outcome and something that's found on a mammogram that's excised, the woman with a palpable lump, she's going to lose her hair. She may not lose her breast because she has probably systemic disease. So this is a huge area of my expertise and concern. Annual mammography, as best as you can schedule it. Right now, we're having our dreaded, feared uptick in cases because guess what? During the pandemic, I don't want to go get my mammogram and get COVID. Well, no one got COVID at the mammogram centers. And unfortunately, we're getting, in my own practice, I have about 2 times the average number of breast cancers since the first of the year. And even in my wonderful educated women, but now we have such a backlog at our breast center, also because a lot of techs quit. So we can't even accommodate the extra demand in women who procrastinated. Anyway, so for a lot of reasons, I just want to say, if I'm on estrogen, if they find something, I'm confident I'm in that data set that my risk of dying from breast cancer is reduced 50% just out of the gate. And the fact that I'm very good. I have a mammogram every year. So I'm in that group that I might have a lumpectomy, but the chance of something really scary and awful is extremely remote. And so, I say belly up to the bar, hug that little machine, and just be grateful that we have the technology. Okay. By the way, another question was asked about progesterone. In 41 years, I've probably had 3 patients that really felt bummed on 100 milligrams of progesterone. It's a very low dose. I mean, honestly, the blood level is almost unchanged from women on no progesterone. However, those mood changes are very real for those women. So we have other things like the little norethindrone that they used in Denmark. It's partly why I showed you that slide, because that's a great product, especially if you have endometriosis, which I think we talked about that in another session. But endometriosis is much better suppressed by norethindrone and NETA than it is by natural progesterone. So these are all little things in the mix. And if you have some of those individualized questions, I would go to a medical center, wherever one is in the United States. Certainly the people at the medical centers who treat those diseases and are at the cutting edge of research are going to have much more current knowledge. And they would know right off the bat what I just said about the synthetic progestin versus natural progesterone. Whereas a typical practitioner, like an internist just texted me this morning about a mutual patient, and she's on the estradiol pill with a little norethindrone in it, and but needs more estradiol. She's super buff, super thin, and she's waking up at night. Anyway, I checked her estradiol and it was like 26. That's not enough. Anyway, so the woman with a grandmother that had breast cancer, there is no dose relationship of estrogen and breast cancer. And in fact, we have a lot of data showing that women with breast cancer history actually are observed to have much lower rates of breast cancer, just like the routine population that you saw a small decrease in incidence. And by the way, Zena, I can't see the chat questions. I
Okay.
saw them come in. If you want to,
Yeah, I'll hit those. So the first one was, how do you determine the correct dosage of estradiol, transdermal estradiol?
well, again, so much depends upon symptoms. So most women will start depending on their symptoms. You know, the young woman who's just recently menopausal and she's going crazy, 0.1, because most rapidly resolve her symptoms. It's pretty rare, too much for younger menopausal patients. But again, then there's the woman who is very afraid of any estrogen. So I start on 0.25. She'll get a little bit better. It'll take a little longer. And you can use something vaginally, a little additional microdose of vaginal estrogen so that she can have sex over the next month or so without pain. So, you can individualize a little systemic, a little local. And then when you raise the systemic level, usually at an 0.375 or an 0.5 dose, no more vaginal dryness, you can drop out the local only therapy. And then we talked about osteoporosis, a very osteoporotic woman, and there are plenty of women who've had eating disorders. They're the group that, drank Tab instead of milk back in the 60s. And they enter menopause with very low bone mass. So often those women, I will show them the data on growing bone, improving density as long as your vitamin D is adequate, and put them on a higher dose. And, then if they want to go down for any reason, we do that once their bone density is improved.
And then on that note, the question was, if you're over 10 years out from menopause, is it okay to start estrogen for osteoporosis reasons, or
Yes.
not a good idea?
In fact, I have a lot of women who are in that category, especially ones that have had a hysterectomy. That's the easiest one. Absolutely transdermal through the skin. And I usually put them on an 0.25 patch to start. I then reach out to their internist and say, for this reason, in so-and-so, I recommend we increase her patch. And again, often these women have been seeing the same doctors while Rome was burning, so to speak. So, then I get her chart. I see what's been looked at, if they've looked at her inflammatory markers, so I know her cholesterol. And again, what I'm really assessing is, what does her cross-section of her artery look like and how much plaque does she have? I know up to an 0.5 patch, there's no increased risk of a clot or a stroke. So that would be probably the way I would address that, because to me, the beauty of estradiol is you build bone and you build healthy bone. We don't see atypical femoral fractures in estradiol users.
Okay, and then if the question is, if they found out you had breast cancer, would you stop using estrogen/progesterone?
So when a breast cancer is diagnosed, there are many factors that we actually look at on the pathology report. So breast cancer is generally found earlier, kinder, gentler. They're usually estrogen receptor positive. If it is a truly invasive breast cancer, not an in situ, if it's truly invasive, then I do gradually wean women off. Many times they'll be on something like tamoxifen or raloxifene that fortunately have estrogen-like activity in bone, and to some degree in brain, so that we don't use estradiol, at least for the first 5 years after a breast cancer that's estrogen receptor positive is diagnosed. There are, unfortunately, breast cancers that have no hormone receptors, triple negative breast cancers. Well, those women actually do very well leaving them on their estrogen. It's not an estrogen sensitive tumor. In a way, of course, I wish it were, because the outcome data is better if you have an estrogen sensitive tumor, because healthy cells, normal cells, still have their estrogen receptors. So when more sinister changes happen in a cancer cell line, they lose their estrogen receptors. So, it's like good news, bad news. Yeah, I'm glad I don't have to have hot flashes, but I'm sorry I have triple negative. So, TN0, unfortunately, also more common in African-American women. So these are all important things to know.
And then are there particular bioidentical products you recommend? Climara, question mark, is there a difference between the brand and the generic?
Well, the generic Climara, here's my hummus. It's bigger than this. It's a pretty huge patch. You wear it for a week. Actually, it's probably on the order of this. But the generic also looks like a giant sort of pinky tan Band-Aid. Doesn't stick very well, but that's been my observation. Brand Climara works just fine. You change it once a week. There may be a new generic Climara that I haven't seen yet. I hope so. Meaning it's just a once a weekly patch. That's what Climara is. Vivel and all the generics that imitate Vivel, which is most of them, are the littler. Often I have one in my desk drawer here, but I don't today. Anyway, they're littler. They are a full 0.1 is this size, and compared to my thumb, it's about a little bit bigger than my thumb. So it's not a horrible thing, but the little baby doses, they're tiny. They're little teeny things. So, but any dose prevents bone loss. The beauty of the Climara, honestly, for women that tell you that they forget stuff, they're right. They do forget stuff. Once a week, every Sunday, change my patch. That's easier. The other patches, you kind of have to divide the week. One time you change it 3 days, one time you change it 4 days. But because the patches accumulate lint on the outside and they get kind of scuzzy looking, it's easy to remember to change it because it looks dirty. So most of us wear the point of the twice weekly change patch types, but either works beautifully, and we can do serum levels, and they really give a pretty even dose through the entire period of time. So like the twice weekly, in fact, the dose drops about day 4.5 to 5. The weekly, the dose drops about day 8, 9. So you get a little grace period. I always tell patients, leave your old patch on until you put your new patch on, and then take your old patch off. Because if you're in Tahoe or some weekend away and you whip off your patch before the shower and then you realize, oh my God, I didn't put any in my overnight bag, you're kind of up the creek and you may not feel very good the next day. It takes a while for the brain to desaturate, but why be miserable at all? So.
And then we had, if estrogen has a dilation effect on arteries, what is the cardiovascular danger to someone who starts hormone replacement after 10 years post-menopause?
Well, that's why I gave the very specific answer about transdermal and looking at her cholesterol and looking at her blood pressure and looking at her family history and, hypertension, high cholesterol. Oh, I even forgot because I don't have any of these, but if you're a smoker, I'll pray for you that you can stop. But I mean, smoking is the worst thing for heart disease. It just like accelerates it in severity and complexity. So I'm blessed. I don't have any smokers on estrogen. I probably have 5 smokers in my whole practice, poor things. But in any event, for normal practices, plenty of women still smoke. Amazing. So cardiovascular assessment first is ideal. In fact, if you're using transdermal, that's why I made the point, up to 0.05, it's not going to accelerate any existing heart disease. But I still feel it's very motivating to have someone say, look, let's assess where you are. So I do a lot of referrals to cardiologists. Most of these referrals are women who are already on estrogen, but have really, in my opinion, not been optimally managed in terms of their cholesterol and blood pressure. It's amazing. I have patients that tell their internist, oh, well, yeah, my pressure it's normal at home. well, do you have the patient actually send you her series of home blood pressure checks? So when I get them, and it's not normal at home, and she's been basically, quote, getting away with this, again, it's up to us to educate women that controlling your blood pressure is numero uno. It's super important. So I can't undo, bad medical management. However, in my opinion, you're better off wherever you are, at least an 025 patch, because it won't accelerate any clotting risk that's pre-existing. And at least you stop losing bone. And maybe it's a little bit better for your brain than being on nothing.
And then one last question here, I think. There's actually two. My clinician just started me on the generic for a lower estradiol patch. Should I be concerned that it's not the Vivell dot she initially prescribed that my insurance doesn't cover?
Most of the generics work fine. I actually use a generic. I get it from Canada. It's called Estradot. It's fine.
Okay.
Yeah.
And then I just started the twice weekly patch and progesterone. I'm finding myself extra tired in the morning. Will that lessen over time as my body adjusts to the hormone?
And I would say for sure to take your progesterone at bedtime. Don't take it in the morning. Because the progesterone, as you first absorb it and it peaks, it makes you sleepy. So,
I'm still feeling the effects in the morning. When I wake up in the morning, I'm still a little like, ooh.
Huh. Well, of course, part of me feels like, such a blessing to feel sleepy as opposed to having insomnia. But you might try taking your progesterone with dinner. Just back it up a little bit.
Earlier.
The other thing, it sounds corny, but I don't know if any of you recommend this. I really recommend before we even move out of bed to take 3 like ujjayi breaths, really get that air moving and, stretch your limbs, stretch your fingers, just like get your little chi moving before you move your body. My yoga teacher taught me that. And I swear it really seems to make me a lot more alert. I stretch like my dog. She does all that before she moves.
All right, great. I think that's all the questions in the chat.
Okay. Well, you've been wonderful.
Yes.
Go forth and proselytize.
Thank you so much for doing this again.
And remember, your homework assignment, you're going to all email Zaina and tell her about your estimate of what percentage of your clients are sufficient.
Yes.
Okay.
Okay. Perfect. Thank you so much.